first session with multidisciplinary approach to retinopathy of prematurity. I first welcome Dr. Divya Alex to present on the topic retinopathy of prematurity, past, present and future.
So good morning all. I thank Dr. Divya Balakrishnan ma'am for giving me this opportunity. So this born too soon babies, why is this subset of population so significant? The preterm birth is the leading cause of neonatal mortality. So from ophthalmic point of view, unfortunately, retinopathy of prematurity is the leading cause of preventable blindness in infants. So the word preventable has to be given so much importance. That means if you act on time, you can save the vision of the kid. So this is the 2010 WHO data. And our country leads the top with 3.5 million preterm births. So this is the 2020 data. So almost the similar pattern continues. So this resulted in strong political commitment to end preventable newborn stillbirths and deaths. So the government set up lots of newborn care, the specialization units and NICUs. So this led to increased survival rate of premature babies who are at risk to develop blindness due to ROP. So imagine if in 2010 there was about 35 lakhs of preterm births, and if at least 30% of these babies have access to neonatal care, about 1 lakh babies are found to survive each year who are at risk of developing ROP and they require screening. So the quality of care needs attention. There is no doubt that many of the centers do an excellent job, but owing to the wide variation in the neonatal care, it is found that more mature and heavier babies develop ROP. So currently, we are going through the third epidemic of ROP. So the first epidemic occurred in 1940s and 50s in the United States and Western Europe. And this was the time when they introduced neonatal care and unmonitored oxygen was introduced. So the second epidemic occurred in 1980s, and this was due to the increased survival of the extremely large birth weight babies and because of the minimal screening and treatment. And the third epidemic started from 1990s onwards and it's still going, especially in the middle income countries. And this was due to the increased access to the medical technology with earlier viability, yet without much of postnatal level of care. So to understand retinopathy of prematurity, we should understand the normal retinal development. So in utero, there is a perfect environment for vasculogenesis. Vasculogenesis is the de novo formation of primitive vascular network. So at the for the vasculogenesis, the metabolic demand always exceeds the oxygen supply. So there is always a physiological hypoxia. So this physiological hypoxia induces hypoxic-induced growth factors such as VEGF and IGF-1. This drives the angiogenesis, that is the growth of new capillaries from pre-existing blood vessels. So this angiogenesis occurs up to the aura. Slowly it occurs up to the aura. So this process starts at 16 weeks of age, and the nasal aura will be completed by 8 months, and the temporal aura will be completed around 9 to 10 months. That is about 40 weeks. So what happens with this too soon born babies? So in utero, if it was the ambient environment, for the preterm babies, no longer the ambient environment exists. So even the atmospheric oxygen is a bit high for them. So then imagine when a baby is having respiratory distress, you start pumping oxygen. So the initial response to this oxygen will be severe vasoconstriction. So the retina sends a false signal that we don't need any more oxygen. So there will be abrupt stoppage of the retinal vasculature. This is the phase 1. So along this period, when the baby stabilizes, we pull off the ventilation, give blended air or room air. There will be a lot of oxygen fluctuation and oxygen stress. So this stress will give rise to oxygen reactive species, releasing the hypoxic-induced growth factors, and this VEGF and the IGF, everything comes back with vengeance. That is, it is almost 100 times more than what was in utero. So this leads to the vasoproliferative phase, that is the phase 2. So this process from the preterm birth to the phase 1 to the phase 2, this almost happens between 3 to 4 weeks. That is why we kept it mandatory that every baby, preterm baby, must be screened for ROP within 30 days from birth. So this is exactly what is happening in the retinopathy of prematurity. So there is a vascular retina, there is an avascular retina. First, there will be a demarcation line between the both, and then it has a breadth, width, height. It is a three-dimensional structure. Now it is a ridge, and the vessels grow onto the ridge and onto the vitreous, and this starts pulling the retina with a partial detachment and then a total detachment. So let's see this through images. So this is the avascular retina. So when you trace the retinal vasculature, you can see the abrupt ending of the retinal vasculature and followed by a translucent zone. This is the avascular retina, and this is a stage 1, that is with the vascular retina and the avascular retina there is a demarcation line, and in the stage 2 this line gets to happen a three-dimensional structure attaining a width, height and a breadth, and then this is the ridge, that is the stage 2, and this is the stage 3, that is the new vessels, new blood vessels starting growing into the vitreous cavity, and the stage 4 is a partial retinal detachment, and the stage 5 is the complete retinal detachment. It can be an open funnel, closed funnel, or the closed funnel with the anterior segment findings such as AC shallowing or adhesions. So this is the closed funnel RD, which was described in 1942 by Terry as the retrolendal fibroplasia. They thought that is the cataract, but this is the end stage of the retinopathy of prematurity, that is the total retinal detachment. So this is the new ICROP classification, that is the 3rd edition. So as we are a part of neonatal specialists, we should be thorough with this new terminologies. ICROP was first developed in 1984, and they made mandatory to screen all preterm babies. For why this 3rd edition? Because of the innovations in ophthalmic imaging and because of the novel anti-VEGF introduction. So this is the zones of ROP. So there is the zone 1, that is right at the center, the distance between the fovea and the optic disc, twice the distance on both its sides, that is the zone 1. And the zone 2, it is the circle that is ending in the nasal aura, and the temporal remaining crust is the zone 3. But in the ICROP 3, they have added a new terminology, that is the posterior zone 2, that is 2 disc diopter peripheral to the zone 1. So this is the posterior zone 2, and this will be the anterior zone 2. So any disease occurring in the posterior zone 2 should be more worrisome. And this is the another terminology that is included, that is notch. So notch means incursion of the ROP lesion by 1 to 2 clock hours into a posterior zone. So earlier you would have called this as a zone 1 disease, but now we know that it is a notch, that is zone 1 secondary to this notch. And now the next term was the plus disease spectrum. So the plus disease was defined from 1985, but now it is considered as a spectrum or a continuum of disease which is associated with vascular dilatation and tortuosity. Whether it is arterial or venous tortuosity, it doesn't matter. It is determined by the abnormal looking vasculature determined by the vessels within the zone 1. So another terminology was the aggressive retinopathy of prematurity. Earlier it was called as AP-ROP, or the aggressive posterior ROP. Now it is just called aggressive retinopathy of prematurity. This was first added in 2005 to describe a severe rapidly progressive form of ROP located in the zone 1 or posterior zone 2. But now it has been increasingly recognized in larger preterm and beyond posterior retina. So they have this the key diagnostic features are the tempo of the disease and the appearance of the vascular abnormalities rather than the location of the disease. So the classic findings will be vascular looping, severe plus a combination of hemorrhages and proliferation. And this may be due to the severe vasoconstriction, which I have already explained, mostly oxygen-induced retinopathy. So these are the changes that came in ICROP 3. So we will be continuing our session with screening, treatment, and whether it is ROP or any other disease. So imagine, so remember that even a single blind child is a tragedy. So it is our responsibility to screen them at the right time and save their vision. So once again, I thank you.
Thank you, Divya Alex, for that wonderful